So basically, this is the topic you're talking about symptoms and fears people have about death and dying, and about how to looking about protecting and enhancing in palliative care. Yeah. And these are the objectives, I think, for this evening that I would see that from my presentation is to provide an understanding of palliative care, the role of all healthcare professionals as well as palliative care specialists. Understand a bit about death in Ireland, where do people die and what do they die from or die of. Looking at the current state of palliative care in Ireland, and then looking at the understanding of challenges facing patients, their families, and health and social care professionals caring for them. So um, I am planning to speak for about 20 minutes, so I'm not going to be covering these areas in depth, but I hope then with the opportunity for questions and answers, I may be able to address other questions afterwards. So there's no commercial conflict of interest, and from the other sort of conflict of interest potential, that I am the Irish Palliative Medicine Consultants Association spokesperson on assisted suicide and euthanasia, and I presented at the Joint Committee of Assisted Dying, as Stephen has already referenced. So I know that this is an audience, mixed audience. I don't know exactly who's here or how many people are here, but I suppose this is a definition of what palliative care is about. And it is to improve the quality of life of people facing problems associated with life-limiting illness and supporting their families. The focus is on preventing relief for suffering by means of assessing and treating pain and other physical, psychological, or spiritual problems. And the aim is to enhance the quality of life and to positively influence the course of the illness. And palliative care extends to supporting the families, both during the person's illness and also into bereavement. This is a definition from the National Clinical Programme for Palliative Care. The National Clinical Programme for Palliative Care is one of the clinical programmes which is run by the HSE jointly with the Royal College of Physicians of Ireland. And the idea of the clinical programme is to promote and develop and to lead palliative care development in the country. I'm clicking, but my slides are not moving. I'm not too sure why that is. Excuse me while I try and see. Oh, there we go. And an important part of palliative care is that sometimes people think palliative care is only about hospice care, only about the end of life, only about cancer, or only about pain. But a big part of palliative care in Ireland, and it has been since the first palliative care policy, which was the report of the National Advisory Committee on Palliative Care in 2001, the palliative care provision is the responsibility of the whole healthcare team, and that there is a team approach to planning and providing care tailored to meet the individual's needs. And palliative care is divided into different levels, 1, 2, and 3, depending on the needs and the complexity of the patient's problems. So the level 1 palliative care is what's called the palliative care approach, and it can be used in any setting or location by healthcare professionals as part of their own role. Level 2, which is the next level up of palliative care provision, is provided by healthcare professionals who have additional knowledge in palliative care principles and use this as part of their role. And this may be some settings such as care of the elderly settings or oncology settings, where there may be many people who are living with progressive fatal illnesses. And level 3 palliative care is what might be called specialist palliative care, provided by healthcare professionals who work solely in palliative care, have extensive knowledge and skills in this speciality, and will deal with people with particularly complex problems. An important thing to think about palliative care is that it is appropriate at any stage from the diagnosis of a life-limiting illness, rather than just at the very end of life. It can be provided alongside active disease management or rehabilitation approaches, so it's not an either-or approach. And it can be provided by primary care, GPs, or by hospital teams, or referred to specialist palliative care if, for some reason, the primary palliative care team or primary care team, GP or hospital team, but they're not able to manage the patient's concerns. And palliative care can be involved for a period of time. Patients may be discharged from palliative care services and re-referred again if required. Because I think that traditionally people thought that once you're referred to palliative care, that you're only ever involved in the palliative care service and you're never involved in other types of healthcare. But this idea of people being involved for a period of time, stepping back first and then being involved again, is becoming much more common. So, let's talk a bit about deaths in Ireland. And over 40% of deaths in Ireland occur in hospitals. And I think this is an important number to be aware of because although the business of hospital is very much about treating people, curing people, getting people well, because 40% of deaths in Ireland occur in hospitals, it is also part of the work of hospitals to care for people who have progressive fatal illnesses. 80% of deaths in Ireland are from people from illnesses of chronic progressive illness, such as heart disease, cancer, lung disease, such as COPD. 20% of deaths are deaths in a more sudden type. That's maybe with a shorter illness trajectory. But for the 80% of people who are dying from a chronic progressive illness, there is a time during their illness that they may have palliative care needs. And most of their palliative care needs can be met by the GP or primary care or by their main hospital team. But it is because I say most deaths are from sort of chronic progressive illnesses, there is that role then for the palliative care approach in the managing of people with these illnesses. So if people are living with serious illnesses, there are a number of sort of broad areas that may cause them concern. One of the big ones that people are always worried about and think about are symptoms. And although many people think about pain as a major symptom, other symptoms include fatigue, poor appetite, breathlessness, nausea. There are many psychological concerns that people may have, and that would include fear for themselves or for their future, but also fear for their family and friends now and in the future. And some of these psychological concerns may lead to anxiety and depression, but also people may have sort of existential concerns about their life and the meaning of their life and the purpose of their life, that they will review their life when they're faced with a serious illness. And a very practical point that people may have is that they have financial concerns because the person himself who is sick may face a loss of income. There are informal family carers, and a lot of care is provided by informal family carers. And informal family carers may have to give up or reduce their work to provide care for people. And then there are increased costs which are associated with having a serious illness. And although people may have a medical card, there's lots of medication which isn't covered by the medical card. People may have or need equipment, again, some of which provided by the state, but other of which has to be paid for by the individual themselves. Very practical things about heating, because if people are sick and not moving around so much, more likely to feel cold and more likely to need more heat. And this is some research that has been done by the Irish Cancer Society looking at people who are living with cancer and the additional costs associated with living with cancer. There's two sort of areas of research I probably want to focus on that might help inform some of this. So I suppose some of the ideas in that around about palliative care and death and dying in Ireland. So the National End of Life Survey was carried out was published in 2023, and this was a survey and was organised by the National Patient Experience Office. And what they did in this situation is that they surveyed bereaved relatives. And the relatives they picked were those who had registered the death. So not necessarily the closest relative or the relative most involved in the person's care, but they contacted the relative who had registered the person's death. When the survey was being designed, they excluded deaths which might have been considered sudden, such as now. I'm just got a message saying stop my video. I hadn't stopped it, so hopefully it's started now again. So it was excluding people who might have had sudden deaths, unexpected deaths, or deaths where there may not have been a predictable trajectory that the person was going to die. And in the National End of Life Survey, there were questions which asked people about the care their relative had received in the last 3 months of life or the last 2 days of life. There's lots of information gathered in this survey, but I'm just going to talk a bit about deaths in 4 different settings, because these are the 4 main settings that they covered, which are basically deaths at home. That included deaths in a person's own house or the house of a family or friend, deaths in nursing homes, deaths that occurred in hospitals, or deaths that occurred in hospices. Those are the 4 main areas. So looking at deaths in the last 3 months of life, there were between 10 or 20 questions, because some of the questions were more questions depending on whether people died at home or in hospital or in nursing home or hospice. And they looked at care across a whole range of domains, including things like, was the person's symptoms well controlled? Did the staff do as much as they could to manage symptoms? Was the help available for the patient just during the working day and out of hours? Did the person have, was there evidence of good coordination of care? Was there information available for families? And were families able to be involved in decision making as much as they wanted? Um, did the patient know that they were dying? Different questions like these were asked. Excuse me. And if you're looking at care in the last 3 months of life, as in relation to care across all of the domains that were rated, it was that care was rated highest in hospices across all domains. So symptoms, access to care, access to support, access to spiritual support. All this was highest and highest rated in hospices. And interestingly, given that there is a fair bit of controversy at times about nursing homes, so the bereaved relatives who described the care that their relatives seen in a nursing home in the last 3 months of life, they had the next highest rating of care, was in nursing homes ahead of after care the high rating of care in hospices. Care at home was overall good, but the main concerns when people were being cared for at home was access to medical help, both during the working week and also out of hours. Another problem about care at home was access to spiritual support, and those are things that they bereaved relatives felt was not possible. And again, care in hospital is overall good, and the main concerns in relation to hospital care was emotional support. And I suppose it was heartening for me to realise that overall most people rated the care as good or very good in all settings, but it did highlight areas where there were some particular problems. In care in the last 2 days of life, there were 17 questions which apply to care across all settings of care. Across all domains, care was rated higher than the national average at hospices. So people who died in hospice, the ratings for care was higher than national average for all of the domains for people who died at hospices. The highest ratings, and where again all of the ratings were above the national average, was for people who died in nursing homes. So looking at the care in the last 2 days of life. Then looking at care at home in the last 2 days of life. For 7 areas, care was at or above the national average, but for 10 areas, the care was rated below the national average. And that included problems such as lack of practical help, lack of nursing support, out-of-hours support, and spiritual support. So these are some of the areas which were rated below the national average when people were being cared for at home. And the lowest ratings for care in the last 2 days of life was for people who died in hospital, and for all areas, all domains, care in hospital was rated lower than the national average. So you can see that when you're looking at what bereaved relatives had to say, that care in hospices was very highly rated, both the last 2 days of life or care episodes in the last 3 months of life, and care in hospitals was overall had the worst ratings. And given that 40% of people die in hospitals, that is quite a concern. But I suppose if you're looking at the end of life survey, what you're looking at there is the care of the bereaved relatives, not the patient. So you're looking at it from their viewpoint, not from the viewpoint of the patient. And also when you're looking at the bereaved relatives who answered the questions, because the questions were sent to the person registered to death, the person who received the survey was said, like, if you feel you're not the best person to answer this question, please pass it on to somebody else. But you're not sure if the person who answered the survey was person who was closest and most involved in the care of the person who had died and maybe had the best understanding what had gone on. And there were quite a number of questions, I say, across different domains between, the last 3 months of life, 10 to 20 questions, last 2 days of life, 17 questions. Not all of these questions may be of equal weight. So some things might be more important than others. So although there might be things which at home are better because you're surrounded by your family and friends, so that might outweigh the problem that you're actually not getting enough GP or nursing support. And also, because these questions are in this case, these surveys were answered by relatives, but what's important to the relatives is not necessarily the same as what's important to the patient. I think a lot of us who work in palliative care, but also a lot of people who work in healthcare in general, are aware that patients and families don't always agree on what's the most important thing. And therefore, it is very important to try and hear the patient voice. But that has been a challenge in palliative care because you're dealing with people who are very sick. So trying to make sure you're hearing the patient voice can be can be a challenge at times. The other study I wanted then to talk about is the TILDA study, which is the Irish study and the longitudinal study of aging. And this is a study which has been running for quite a number of years and recruiting people and then over the age, I think, of 50 and then re-interviewing them by sort of resurveying them every few years to ask various questions about their health, about their well-being, about medication, about various problems they may have. One question that's in the TILDA study, and this is a report from the TILDA report of 2021, that about 3% of community dwelling older people expressed a wish to be dead. And the wish to be dead, or the wish to die, expressed in the TILDA study, was associated with people with loneliness, also associated with undiagnosed and untreated depression. And in the TILDA study, the patients would have reported if they had depression, but they were people who had undiagnosed and untreated depression, were people who, based on their survey responses to questions about depression, probably had depression, but who had not actually been treated for it. And then the other group for whom there would be had this expressing this wish to be dead were people who had multiple comorbidities. So people living with multiple different illnesses. This wish to be dead fluctuated. So because the TILDA study is repeated every 2 years, so although 2 years later, still about 3% of community dwelling older people in Ireland did express a wish to be dead, they're not the same 3% who had expressed that wish 2 years previously. So it does fluctuate. I don't think TILDA have reported on had there been other changes in these people's lives that might have increased or decreased their desire for death over those 2-year periods. So if we're looking at the sort of issues that sort of affect or concern patients who are living with serious illnesses, one big thing is the issue about services and lack of services. Very often, patients are concerned about being a burden to their families maybe having to give up work to mind for them and care for them. And one thing that the HSE provides is what's called home care packages. And home care packages are funding provided by the HSE that carers can be employed to provide support to somebody who's at home. And to get a good home care package in Ireland probably means that you would have probably something like a maximum of 42 hours a week. And you'd get 42 hours a week if you need 2 carers. So basically what you're getting is 3 hours a day, 7 days a week of 2 carers. And you would need 2 carers if you need to transfer in a hoist, or you need 2 carers for moving people. Because that means if you got those like 21 hours of care provided by the HSE, that leaves then the other 147 hours a week where the care is being provided by family and friends. Not everybody needs continuous care, but sometimes then people may need care overnight, or they may need somebody available overnight if they need some assistance. And they're the types of things that can make difficult for families to try and support people at home, because if the patient aren't sleeping well at night, the family aren't sleeping well at night, then life can get more complicated. They need access and timely access to equipment, so things like hospital beds or commodes or hoists. These are the type of things that can make it easier for people to be at home, to stay at home, but it can be difficult sometimes to get these, and these things can actually delay people discharged from hospital. Or when people are at home, it can mean that care can break down because it's not possible for a family to keep providing basic care. Our GP services at the moment are overwhelmed. There's not enough GPs. The HSE is trying to address this by training more general practitioners, but the population is rising and the population is aging, and whether GPs are being trained fast enough and in enough numbers to address this is not clear yet. And then the last thing which has become much more of a challenge in the last few years is the thing about drug availability. So although the GMS provide, like the medical card, this provides drugs free for patients. There's quite a range of drugs which are essential for people living with serious illnesses, which are not covered by the medical card. And some of these drugs are like potentially cheap drugs, but if you haven't got a lot of income, even cheap drugs start all adding up. So a very basic thing is laxatives. Most laxatives are not available on the medical card. If people can't afford to get drugs, there are things called the hardship scheme, which is a complicated way that patients will get drugs for free from their local chemist, but the chemist has to apply to the HSE for reimbursement. But it's quite a complicated scheme, and it does mean that, for again, some chemist shops are not willing to engage with it because of the bureaucracy involved and the lack of guarantee that they're actually going to get some money. There are also then a lot of shortages at the moment. Some of these are supply chain problems that are affecting the whole world. I think Brexit has had an impact, which is a continuing impact on some drug supply. The Irish government pricing system, so the Irish government, the Irish government will buy drugs, so they will bulk buy drugs, but at the same time they're a small market and probably paying a lower price. So bigger markets and places will pay more. The company is going to sort of prioritise them when there's a drug shortage. And the last thing to talk about is what are sometimes called orphan drugs. So basically drugs which are not commonly used. And if they're not commonly used, they're not commercially viable, and then it is more difficult then to get those. So currently working as a palliative medicine specialist, our pharmacist in the hospice every week sends out a list of the drugs which are in short supply or not available. And then you have to try and think, well, if those aren't available, how are we going to work this out? And if we're working in the inpatient hospice, we have maybe more control over things, but if you're trying to help patients stay at home and work with their GPs, there is then that difficulty of what drugs are available and how can they be got. And you may have drugs which are licensed everywhere in Europe, but not licensed in Ireland, a particular brand of a drug, and therefore they're not licensed, they're not on the medical card, and therefore you get back into the whole problem with the drug payment scheme. I'm just going to go back a bit to talk about home care packages and the practical hand-on care. So this care is provided by care assistants, which are employed through agencies. And like these are relatively low-paid jobs. So there's a lot of staff turnover within the jobs. And at different parts of the city, there may be more difficulties in actually getting staff. So although the HSE might provide the funding, it may be difficult to get staff. That's a thing that you would notice in Dublin. Again, working on the north side of Dublin, you're aware that if I work in Beaumont Hospital, patients may be coming in from County Meath. It seems to be even more difficult to get carers in County Meath because apparently the County Meath agencies pay less than the Dublin agencies. So people who live near the Dublin border will work in Dublin and get a higher salary than people who are working in County Meath. So these are challenges to sort of provide support for people. Another challenge is the how staff can be supported, because although we may say that most palliative care can be provided by primary care teams, by GP, by hospital teams, all of these people are very busy, but also they have a lot of other things that they need to learn and keep up to date with. So how do you provide the sort of appropriate palliative care approach training to staff? How do you sort of provide staff training in relation to providing emotional support, and maybe then staff being able to recognise when do people need a good listener and when do they need more specialist referral to a social worker or a counsellor? Similarly with spiritual support, what is it that all staff feel comfortable in considering and addressing? But then if you do need to sort of get access more formal spiritual support, there is difficulty about that, about getting chaplains, both, healthcare trained healthcare chaplains or say local chaplains from different religious communities. A really important part of all of this in relation to palliative care is the idea that no matter how good palliative care is, you are in a situation that people are facing a life-limiting illness, and how do you cope and how do you talk to people about a life-limiting illness, thinking forward to a life-limiting illness, and how do you tell people bad news in such a way that they can understand what's going on, that you as the healthcare worker talking to them can understand how much information they want, and that is a way that's said to them that is not overwhelming or dramatically sad. But at the same time, I see people who are looking for straightforward information, having the skills to give that. Another important communication skill is the idea about advanced care planning. So thinking further into the future. How do you provide the care? What do people want in the future? What might they want? And I think the thing in relation to sort of providing care for people in these sort of situations, like patients may have a lot of medical symptoms. There's a lot of concern that people are, and I'm putting this as a blank statement, it may not be completely true, but sometimes when people are dying, as in the last days of life, there's a tendency for people to assume that all the stress is from pain. But I think what you need to then do, but then maybe under managing the other problems that people might have. People can have a lot of discomfort from a dry mouth, from urinary retention, from stiffness in their limbs, from pressure areas. And these are the type of things that you need to have staff know what they're about and trying to assess these. If people are being cared for at home, how do you support families to recognise these things and how you can support family to be able to do some of the care for people at home, turning them in the bed, sort of trying to look after mouth care. A very common problem, unfortunately, with people who are getting very sick is delirium, which is a confusional state. And people can be agitated and unsettled and frightened. And it can be very unsettling and frightening for both the patient and for the family. But sometimes this is mistaken for pain, and then people are giving opioids and strong painkillers, which can make the delirium worse rather than improving things. So it does take skills to try and recognize why people might be distressed and what may be the problem. So I sometimes say this to families, like the pain is not worse because somebody is dying, but they can be distressed. So what is the stress and how is the best way of managing that and try to identify that? I think that, and then just sort of stepping into this a little bit because something that comes up in relation to, and I said this about, say, the end of life survey, these were bereaved people who were asked the question because sometimes the patient wants and what the family wants is different. And there is that problem then in relation to for patients are being cared for at home or in hospitals. How do you know if people are being coerced or there's been sort of they're being put under pressure? And that can be like, so patients can sometimes put families under pressure and say, I want to be at home. And it may not be possible for a family to do that. But on the other hand, families may put patients under pressure and say, you should be in a nursing home, you should do this. And that is a concern, I think, in relation to assisted suicide and euthanasia, because healthcare workers are not particularly good at recognising coercion. And I think there has been a lot of reports about coercion to, say, the National Safeguarding Office. And most of these reports are actually in relation to family and friends of patients or also staff in organisations. And that is a concern for people who are becoming more ill, becoming more vulnerable. And the quote at the bottom is the quote from the High Court, where the judge has said these are the people who might be at risk if you're looking at providing something like assisted suicide or euthanasia. That these are the people who are more at risk of coercion. So when people are sometimes talking about assisted suicide or euthanasia, they might be talking about it because they're concerned about being fear of being a burden, or else feeling a loss of identity or loss of purpose, or loss of independence. But a big driver, and most in the research which is showed, is that for most people, they look for assisted suicide because they don't want to be a burden, because they've lost independence. And they feel that, and this I think is a really big concern because I think there are many people who live with serious illness. And I think people living with serious illness and disability, how do you define the life of a person with disability? Is that defined as a life that is worth living, or is that defined as a life that is a burden to themselves and to others? So whether that's people with disability or people with serious illness,